what I represented to her was probably quite confusing. Someone who is supposed to be a safe person, but perhaps somebody who might appear safe but actually have some sort of alternate agenda.
Because that's what she'd been exposed to in the past.
Yes, she was no longer in that environment anymore, but she'd been understandably hugely traumatised by it, and it had shaped all of her subsequent relationships, both on a personal level and a social level, with school, with social workers, and anyone she came across really, but particularly with men.
So trust for her had been broken repeatedly.
That's right, and trust is one of the most important things that we have as a clinical tool with working with young people in mental health. They have to be able to trust that the type of talking we're doing with them is the right sort of therapy, that the medications that we may or may not prescribe are going to be helpful for them, and so on, irrespective of whether they believe we really want to help them at all.
Did you feel a bit helpless at times in that situation? Did you manage to gain her trust?
I felt helpless about what had gone on in the past. There were things that I knew that I could not change. And I would often say that to a patient: I can't wind the clock back for you, I wish I could. And trying to bring a focus on what can I do for you in the present moment that can help for you in the future is the place to start. But such cases do make us feel completely helpless, because we can't help but visualise the distress that young person must have been in before. And understandably, they can also develop complex and confused feelings towards us as the therapists. And we have a name for that, we call it transference, when the young person perhaps may put us in a position where we represent the abuser, for example. And that's very hard to deal with. We have to be very mindful of the things that we're saying with young people who have been abused, so we don't reenact abuse, not in a literal sense, but to reenact situations where that young person may feel that they have been re-exploited in some way. Fortunately, the wonderful thing about working in mental health is that the systems are set up to support the professionals to be very aware of what's going on in their relationships between them and their patients, to take time to reflect on that, to discuss it with colleagues, and make sure they don't fall into those sorts of traps with people.
So you can often become the subject of one of your patients' anger?
Absolutely, that happens quite a lot. And equally, the opposite of transference, which I mentioned, counter-transference, is the powerful feelings that we develop about our patients, and understanding the meaning behind those feelings, where they're from, what they really represent, is a bulk of the work, actually.
Is there a danger that you can become desensitised if you deal with these kinds of issues day in, day out, again and again? You obviously have to find a way of coping with it so that you're emotionally secure. Can the switch off button go a little bit too far the other way?
I'd say in my experience, people tend to burn out rather than become desensitised. So I think if professionals absorb cumulatively over a long period a number of stresses that they haven't been able to deal with themselves for various reasons, of course our home lives, our outside of work impact on how we're able to deal with these things as well, then it tends much more to be the case that staff might go off sick, for example, or recognise